Hello.
Hi there. Welcome to From Skirts to Scrubs. I'm Charlotte.
And I'm Alicia.
And we are two medical students trying to figure out our place in medicine by looking to the past and to current events to try and understand the impact they have on us as women in medicine and as women in general.
Yes, and you can find or follow us on social media. We have an Instagram and a TikTok, which are both at From Skirts to Scrubs. We have a Twitter, which is at FSTS_podcast. And you can check out our website for more information on our episodes, show notes, sources, merch, and more. And that's from skirtstoscrubs.com.
Yeah, and you can also subscribe to us, leave us a rating and review. Apple Podcasts and Spotify are fantastic places to do both of those. And we also now have a YouTube where you can watch us talk as we are now on the podcast. And you can check out all of those episodes. They'll be on our YouTube channel, which you can also subscribe and give us a like there as well.
Yes. So let's just get into this episode. It's a good one. It's a biography, always a fun time. Today, we are going to be covering the life of a perhaps well-known, perhaps not so well-known woman named Virginia Apgar. And before we kind of get into this woman's amazing life, I don't have much of a preamble or a prelude. So Charlotte, just tell me what you know about her. Tell me all the things, what's she known for? Literally anything you got.
All the things. I don't know that many things.
No
So I
things.
can't give all the things, but I honestly know nothing about this woman's life. I know that she created or had a role in the Apgar Score. I know that the Apgar Score is something that you give a newborn baby like within like a minute after life and 5 minutes and 10 minutes. It's just a way for the pediatricians to gauge how the baby is doing and what interventions they need to complete to make sure that the newborn is okay. And that it doesn't really have any like influence in a child's life. It doesn't predict anything. It's just part of that like initial assessment of a newborn. And that's all I know about it. To be honest, I maybe know how to grade a baby, but no, not much. No, I don't know much. We can move on.
All right, then let's just get right into it.
Let's do it.
All right. Alrighty. So Virginia Apgar was born on June 7th, 1909 in Westfield, New Jersey. Her dad was named Charles, and he was a businessman, amateur inventor, kind of a jack of all trades type of dude. He owned a successful insurance agency in Westfield. That's like fact about him.
Okay.
Her mom, Helen, was a homemaker and dedicated herself to raising Virginia, or Ginny, which is what I've been calling her, and her two siblings. Thanks. Not surprising that Helen was a homemaker. Kind of fits the times. And, we're going to let her do that. Good for her.
Mm-hmm.
Ginny had two older brothers, Roy and Alan. And we don't know much about their family or their family dynamic, but what we do know is that her family placed a heavy influence on having intellectual curiosity and valuing education. And so Ginny wanted to be a doctor by the time she graduated from high school. And this is partially because of that kind of intellectual spirit she had, partially because her dad, like I said, he's a jack of all trades type of person. So he had all these scientific hobbies he was interested in. And then also because she just wanted to help people. Her oldest brother, Roy, actually died very early in his life from tuberculosis. And her other older brother, Alan, had polio in childhood. And so both of these, having this kind of experience taking care of them and being around them growing up, also inspired her to pursue medicine.
Wow, that's unlucky circumstances for this family.
I know, it is unlucky. And it's like very typical, I feel like.
Yeah, for the time, for sure.
Mm-hmm. She went on to go to college at Mount Holyoke, which was in Massachusetts, where she got multiple scholarships to go there, and she studied zoology primarily. But she also, I know, kind of random, but like maybe it's like their bio equivalent. I don't know.
Yeah, that's what I was saying too. Like so many pre-meds are bio majors. Maybe you learn a lot of like animal stuff. So I guess that's also kind of zoology.
Yeah. She also, though, played the violin and the cello and even performed in her college orchestra, which is fun. She was keeping it well-rounded, which, like, good for her. And also, fun fact about her is, this is so random and, like, I don't know. She had a job in college at a research lab, don't ask me much about the research lab. Like, I don't know anything about it, but her job was to round up stray cats.
What?
Which is so random.
Her whole job was being a cat catcher?
Yeah, and I guess maybe they did research on the cats. Like, I couldn't tell you.
Damn.
But
Okay.
that was her job in college, a little snippet into her life. And she graduated from Mount Holyoke in 1929 and then went on to study medicine at Columbia in New York in 1933. Yeah, I know. Good for her. But it was literally the middle of the Great Depression. So she was like pinching pennies to go to this medical school, which granted was a lot cheaper than it is now, but still it's not nothing. Like, she paid a lot of money.
Yeah, wow.
And
where'd
she was only one of 9. I don't know. I maybe her parents helped her. Like, I couldn't tell you.
Yeah.
But she made it work. And she was one of only 9 women in her class of 90 to be getting an MD at Columbia, which is also pretty typical. I'm not that surprised.
Yeah. 10% of the class.
Yeah.
Adds up.
She graduated 4th in her class and then went on to do a 2-year surgery internship at New York Presbyterian Hospital, which is where she wanted to be a surgeon. That was like her original goal.
Yeah, now I'm interested to see how the rest of this goes, knowing where she ended up.
Stay tuned. Buckle up, Buttercup. So while she was there at this 2-year internship, she had a mentor who was the chief of surgery there named Alan Whipple, which I wonder.
Anyway, is it the man who made the Whipple?
I don't know. I don't know if it was the man who made the Whipple, but his name was Alan Whipple, and he told her that he was very worried that she wasn't going to be able to establish a surgical practice as a woman. And so instead, he encouraged
did make
her.
the Whipple.
Oh my God, that's crazy.
Yeah, he was an American surgeon known for the pancreatic cancer operation, which bears his name.
That's wild. Well, good for him. Well, he's also the same person who told.
Also being mentored by her.
I know.
Or not mentored.
Well, he did tell her that she shouldn't be a surgeon.
Oh no!
And told her. Well. Here's my question though: is like, do you think it was a good call on his part or kind of rude?
It's tough because I feel like some surgical mentors tell interns that they shouldn't be a surgeon, or that like they're disgusted by their surgical skills as a way to like make them feel worse about themselves and like be a bad mentor. And I've heard that story from interns before, but then there's like maybe it was good advice and it was like maybe this just isn't your calling and like you would be better fit somewhere else. That's a different discussion than just saying I think you're a bad surgeon, I don't think you should do this, like rather than trying to teach. But if they're just not vibing with it and you're like, maybe you should switch specialties, then maybe that made sense. I think it's all about the delivery.
Yeah.
So
I think so too. I was going back and forth on it, and then I
might have been a good call.
Yeah. I was going back and forth on it, but then I actually found some like quotes from him, which were all very positive. Like he was like, she's very talented and gifted, but I just don't think that the field would like let her live up to her potential. Yeah. So Ginny decided to instead pursue anesthesiology, which at the time was something that mostly nurses were doing. But she took Alan Whipple's advice. I know. And she threw herself into anesthesia residency. And because anesthesiology was not generally recognized as a specialty until the mid 1940s, Ginny really struggled to find a training program after she completed her surgical residency in 1937. And so she ended up spending 6 months training with Dr. Ralph Waters in his department of anesthesia, which was the first in the United States, and that was at the University of Wisconsin in Madison. Yeah, kind of random. I didn't know that, but good for you, Wisconsin.
That's super random.
And she spent 6 months, or she did her, 6 months of residency in anesthesia there, and then spent another 6 months with Dr. Ernest Ravenstein at Bellevue Hospital in New York, also doing kind of anesthesia work.
Okay.
And so in 1938, When she was only 28, she returned to New York Presbyterian Hospital as the director of a new division of anesthesia within the Department of Surgery. So surgery was its own thing, and then a subpart of surgery was anesthesia. It wasn't its own department. And she kind of became like the new program director in a way, but wasn't being called the program director, but there was no program. So there was no program. And so she was in charge of building up the anesthesia program. And that was kind of her role. But even with her title, like she's a doctor, I think they made her a professor, but even so, she had a very hard time recruiting people to work for her because surgeons didn't see anesthesiologists as equals, and their pay was a lot lower because they weren't as respected. And so people just weren't attracted to that job, which is crazy to think. I mean, obviously, like, ideally, in the ideal scenario, surgeons have like so much respect for their anesthesia colleagues and like recognize that they are truly equally, if not more valuable, in my opinion. But back then, that wasn't the case, and like people didn't always see it that way.
It's funny. It was like
so
undesirable.
It is
now it's really competitive to get into anesthesia.
Yeah,
and,
it's like
very well paying
and like amazing job, like really an amazing specialty to enter. But people didn't want to do it then. And it didn't even exist as a specialty until like the 1940s, which is interesting. So
kind of makes sense based on what we know about when anesthesia was even developed. Just more behind.
Yeah, it does. Yeah. And poor Ginny was literally like the only staff member at this hospital until like the mid 1940s. So like she basically like worked for like 10 years ish as like the only only anesthesia provider at this hospital.
Wow. She's really running all the ORs.
I don't know how she did it, and I don't know. I think it wasn't just her. She was the only doctor, but there were nurses, you know.
Yeah, it's like today. You have like so many nurse anesthetists, and then there's like one doctor who runs like 4 ORs, and the nurses like all sitting there.
Right. Yeah. So that was her, and by 1946, anesthesia finally began to become an acknowledged medical specialty with a required residency training and kind of all the shebang. And in 1949, so 3 years later, when anesthesia research became like an academic department, Dr. Apgar was appointed the first woman full professor at the Columbia University College of Physicians and Surgeons.
Oh, wow.
So she was like the first real deal anesthesiologist at in this department, which is really cool.
Yeah. Wow.
Yeah. Well, the first woman, at least. I mean, as we know. But for a while, Ginny was just out here grinding. Like, poor woman was just slaving away. From 1949 to 1959, she was a professor. And then when the anesthesia department broke off of the surgery department and became its own department, it was led by one of her colleagues and friends, Dr. Emanuel Papper. But when he kind of took on that role, which was a role that she wanted, but then they ended up just giving it to him, and you know, she was salty but was okay.
Yeah.
Eventually, Ginny just went and became the director of obstetric anesthesia.
Oh.
So, for those of you who don't know, obstetric anesthesia is basically like the effects of anesthesia given to a mother during labor, and like it's looking at the effects of anesthesia on her pain, on her vitals, and like, you know, her heart rate, blood pressure, all those things, but then also the effects on the newborn baby. So it's like looking at anesthesia relating to mom and baby, mother baby. So in this role, she went to a bajillion births, like a ton of births. And as you can see now, you're probably starting to think, okay, like finally we're in this role in which I'm like,
I was like, how is she an anesthesiologist? And how is she getting into pediatrics? Okay, it's making more sense.
I know. Well, she was a surgeon before, so it's like really confusing. But yeah. So this, my friends, is what sets us up for understanding the foundation of this Apgar score that eventually comes. So essentially, Ginny was noticing that newborn circulatory and respiratory issues weren't as quickly, like, physically apparent. And people, like doctors, were catching these issues really late. And so there was a lot of neonatal deaths because people weren't looking for the right signs because they didn't know what to look for, because there wasn't a standardized practice of what signs you need to look for when a baby is born to decide, is this baby okay or not okay?
Yeah.
And Ginny was getting really good at quickly assessing whether a baby was okay or not okay within the first minute of life, just by like looking at the baby. And she also got really good at looking for birth defects, looking at the effects of labor on a baby and how they tolerated labor and whether that was going to affect their first days of life, and also understanding the effects of maternal anesthesia on said baby.
Okay.
And this is a fun story. So apparently, one day in the hospital cafeteria, a medical student, this is like lore. I don't know if this is really true, but this is like the lore behind it. Apparently, a medical student went up to Dr. Apgar and was like, "You always tell us to look at the baby when it's born, but what exactly are you looking at?" And then, as the great teacher that she was, Ginny grabbed a napkin and wrote down 5 things to look for when a baby is born, including like heart rate, breathing, muscle tone. I know, isn't that so funny? And that's how the Apgar score was born. Because a medical student asked a question.
Lore. Always ask questions.
I know,
Don't be afraid to ask questions. That's funny.
I know.
Though.
That's why I'm like, if you're a medical student, you should ask questions. Like, your curiosity might lead to something that actually has like amazing clinical impact and save the lives of like billions of babies.
Yeah, for sure. And if your superiors are not okay with you asking questions, that's their problem and not your problem. Like, always ask questions. Oh, you're there to learn. You're a student. That's your place. So that's super cool, though. That's like very much giving like Grey's Anatomy got married on like a sticky note, like, you know, just like ideas being written on a napkin, like little things. That's funny.
I know. I thought it was cute. And whether it's true or not, I'm like, who's to say? But it's headcanon to me.
I like it. She was like, these 5 things, Ginny, obviously.
I know. Yeah. Or maybe she was like, I understand that is confusing for you. I don't know. But Ginny, along with her colleagues, Dr. Duncan Holliday and Dr. Stanley James, did a bunch of clinical research after that point. And so they were looking at new methods of measuring blood gases and blood levels of anesthesia and trying to see if like babies' blood gases were less optimal if they had more kind of exposure to anesthesia or certain anesthesia. And so they were actually able to show that babies with low levels of blood oxygen and very acidic blood, which means they had low blood oxygen, had low Apgar scores. And it was actually because giving cyclopropane anesthesia to the mother was causing these low, or like leading to these low Apgar scores. Have you ever heard of cyclopropane, Charlotte?
I don't know. I don't think so.
You didn't learn about it on your anesthesia rotation that you barely went to?
Listen, my anesthesia rotation, I was not there. But so no, I didn't. I actually asked to stay on my OB anesthesia day, and they asked me why. I said, I can stay. And they said, why would you want to do that? And I was like, because I'm going into OB and I want to learn more about OB anesthesia. And they were like, okay. And then we watched Love is Blind. And so, yeah, that was my one day on anesthesia.
That's funny. Well,
yeah,
good for you.
So I don't know. I didn't learn anything. Yeah, I know.
That's okay. I would have been shocked if you'd learned about this because actually, like, 1, I hadn't heard of this, and 2, they don't use it anymore. So cyclopropane.
That makes sense then.
I know. I just wanted you to admit that you hadn't been going to school.
I went. They just sent me home early every day.
So cyclopropane anesthesia is when they used cyclopropane gas as an inhalation anesthetic. It was highly flammable, non-irritating, and non-explosive, and it was used in the early 20th century primarily as an anesthetic. It gained popularity in the 1930s and 40s because it would rapidly onset. So, like, you could give a little bit and it would quickly knock the patient out. And it had a relatively quick recovery time compared to other anesthetic agents. But Jenny and her team were noticing really horrible effects of this anesthesia on their OB patients. And their research was combined and compiled in this project that they worked on, like a big collaborative project, a 12 institution study that involved 17,221 babies. And it was through this actual peer-reviewed research that the Apgar score was established. And you can even read the original papers. Like in studies now, when they refer back to the Apgar score, they will literally cite Virginia Apgar's like original paper about it. It's crazy.
Yeah.
Yeah, from like the 1940s and 50s. But the Apgar score was like, especially the 5-minute score, was shown to be able to predict neonatal survival and neurological development. And Ginny went on to present this work at a national anesthesia conference in 1952 and published it in full manuscript in 1953. Which is this
awesome
thing that we can like now refer back to. It's really cool.
Yeah.
So what is the Apgar score? You're probably like, what's going on? But before I even say that, like nowadays, the Apgar score is used worldwide because of the impact of this woman's work.
Wow, I didn't realize
basically,
it was worldwide.
Worldwide. And basically, like this score is taken 1 minute after birth, and it is, in very broad terms, a guide to determine the need for resuscitation. So, like Charlotte said, it's not like it tells you, oh, okay, I know that this kid is gonna grow up and go off to Harvard and live like this amazing life.
Either
like,
going to be an NFL player or not. Like that's not the Apgar score.
No, that would be crazy though. The Apgar score essentially is like, in the first few minutes of life, do I need to resuscitate this baby or are they going to make it?
And resuscitate is like if a baby, like CPR on baby, more oxygen on baby, like things to keep the baby
like giving
alive,
them oxygen, intubating them, giving them a tube to help them breathe, that kind of vibe. And so that was like her work was like the 1 minute guide and then the 5-minute guide. And those two became standard. Now I think they also do like 10 minutes. So it's like 1 minute, 5 minute, 10 minute Apgars. And I've been going on and on about this Apgar score, but like, what is the Apgar score? Do you remember? You knew I was going to ask you this. Like, that is just like a natural thing for me to ask.
And I could have looked it up, but I didn't know what we were recording on until I opened up the document before we started recording. You look at like the baby's color, I think. Like if they're pink or blue or whatever, how much they're moving. Like their arms have to be like moving, like you can't see me unless you're watching YouTube, but like you're flexing and extending your arms and legs. It's like the cry, I think. It's like I think if they cry is 1, that's 3. There's 2 more.
There's 2 more. Those are pretty good. Those are good starting points. So you're right. The Apgar score has 5
3
parts.
For sure. Yeah.
Solid. So the first
how
is
much
color,
you're breathing?
like you said.
Something like that.
Yeah. So the first is color. The second is heart rate. The third is reflexes. The fourth is muscle tone, which is what you said. And the fifth is respiration. And each of these are given a score of 0, 1, or 2. So for example, a newborn who scored 0 in color would literally be like blue. 1 would be like mostly pink or normal, but with like blueness in the extremities. And 2 would be like all pink and normal. Honestly, most babies tend to have a 1 for color because it's normal to have their extremities be blue, but it's not normal for their whole body to be blue.
Yeah, you don't want like their face and chest to be blue. That means not enough blood flow.
And so the points are totaled, and that's how you arrive at the Apgar score. So the total like biggest Apgar score, or like, maximum Apgar score you can have would be a 10 out of 10.
Yeah.
And
I don't think I've ever
Apgar
seen a 10 out of
scores,
10 baby.
I've never seen a 10 out of 10 baby. Honestly,
can't
most
have a
Apgar
perfect
scores I've
Apgar.
seen are actually out of 8. And so I feel like I mostly see like 6 or 7s out of 8. And that is totally fine.
For
But
sure.
important to pay attention to. And
Mhm.
the Apgar score gives a number to go along with clinical signs of neonatal respiratory depression, like cyanosis or pallor, which is like if they're pale or blue, bradycardia, which is if you have like a low heart rate, if you have decreased reflex response to stimulation. That's why like when a baby's born, like they try to get the baby to cry. That's the first thing, because that like makes you
That
feel
big
better
breath
about
in.
them being able to breathe.
Yep.
But then also you're trying to like check their reflexes and their muscle tone. Like the worst thing you could have is like a floppy baby. That would be a bad sign.
You want the baby to be moving its own arms and legs. Like when the team is like telling the baby like move, you're like rubbing its little foot and you're like stimulate the baby.
Yeah.
That's what's happening.
And
after babies
it's
are
helpful
born.
to know too that even if their whole body is like moving, but their shoulders not moving or something, then that also can indicate to you that something's wrong with like one small part. It might not mean that like the baby's not going to make it or the baby's like needing respiratory help, but it also could be like, oh, maybe the baby's shoulder got stuck in the mom's vagina, like birth canal, and so then needed a little extra help. But as a result, like the shoulder kind of got injured, and that can happen. So those are signs that pediatricians and nurses and obstetricians in theory are looking for. And the score is reported at 1 minute, 5 minutes, and then at 5-minute intervals until 20 minutes after birth, until an infant has a score like higher than 7, essentially. So I didn't know that, but that's when I looked up the official like actual
guidelines,
description and definition of an Apgar score. That's what it is. So you have to keep taking serial Apgars until they kind of perk up. And one thing I think is fun is that Apgar is, totally Ginny's last name. It's like Virginia Apgar is her name, but it's also a great mnemonic to remember the parts of the Apgar score. So Apgar, APGAR, is appearance, like color, pulse, like heart rate, grimace, like if they have reflexes in response to stimuli,
you're grimacing,
activity, do they have muscle tone, are they able to move all their extremities, and respiration.
Wow. So what if she she came up with that? She was like, I need to add
crazy that her last name fit
she's like,
perfectly.
I need something. Yeah. She's like,
she's literally such a winner.
She's like, when like Voldemort was definitely looking at his name being like, Tom Marvolo Riddle. How do I make this into I am Lord Voldemort.
It all work in this stupid diary.
And you're like, whoa, this is Virginia Apgar being like, appearance. Like
she didn't even do that. Like I wonder if someone else did it in post, but
it's
so
funny to imagine though.
Oh, I know. But after the Apgar score was created, neonatal intensive care units were started. So NICUs started kind of being created after that point, because then they were like, yeah, we need like resuscitation bays for these babies. And not only that, but after her scoring system came out, all of ICU medicine changed essentially. Because we started to have more standardized scores to take care of patients. Well, even adult ICU medicine changed.
Oh, what?
Yeah, so for example, the Glasgow Coma Scale is a way that we determine how much the central nervous system has been impacted, like in a person with a coma. And GCS scoring was created after Apgar scoring because it was a really nice way to know, to take a number and have it correlate to clinical context. So like the lower the number, the lower the GCS, the like worse their coma is or the worse their outcome is. And it's because of Virginia Apgar's scoring scale. And so then intensive care medicine, critical care kind of like took off from there, which is really cool.
That's actually
and like
crazy,
a huge impact.
There are so many scores now, like so much that like doctors can't even
Yeah.
keep track. That's like MD Calc is a really popular app and website for doctors because there's so many scores, and the scores help you grade diseases and treatment algorithms, and just like it's super evidence based to use scores, and that's all about what medicine is now, is evidence based. So that's so cool that it came, like a lot of it came from the Apgar score.
I know, I agree. And she was just this really cool lady. I mean, lived this cool life, like went from surgery to anesthesia to having this impact on the peds world in this crazy way. And actually, in 1959, she like didn't exit clinical medicine, but kind of took a hiatus and got a master's in public health, so an MPH from Johns Hopkins, which led to her role at the National Foundation for Infantile Paralysis, which is now known as the March of Dimes. So it's like kind of the like National Polio Organization, and now is the March of Dimes, which you might have heard of.
Yeah.
And she was basically at the March of Dimes from 1959 to 1974, and was just doing really like a ton of patient research and patient education. And it was in that time, like in 1964 and 1965, when the rubella epidemic hit the United States really hard. And Ginny launched programs to push rubella immunization, and even lobbied in Congress to get more funding to like improve rubella immunization around the country. And she was also really huge in promoting RH, like immunoglobulin shots, to help prevent infant death. Because like basically RH is like a protein and can cause infant death when the protein like doesn't match with the mom's protein. Like it's a whole thing, but essentially like if you get this shot, you can prevent infant death. And it's all just from that shot. It's crazy.
Wow.
I have a friend, like a very close friend, whose grandmother was having serial miscarriages because she didn't realize that after her first baby, she was RH positive.
Yeah. Or she had the antibodies.
She had the antibodies. That's what it is.
Yeah.
She had the antibodies because her first baby was RH positive, but she was RH negative.
She was
Again,
RH negative.
it's a whole thing. But it's just crazy because she was having these serial like miscarriages, but had no idea why. And this shot can literally prevent that.
Yeah. Yeah, that's crazy.
Yeah. So Ginny was very crucial in like helping increase awareness about these shots and helping prevent infant death. And she also co-authored a book called Is My Baby All Right?, which helped parents break down.
Oh my God, that's so cute.
Is my baby all right? And it was a book to help parents break down the stigma around birth defects. And like having a baby with birth defects. And I know.
Oh my God.
She's so cool. I know. Outside of medicine, Ginny never married. She was pretty.
Oh my God.
Well, she she did do
so
more.
much already.
She's so cool. So outside of medicine, she like never married, but she like was a girl who had a lot of hobbies. So she was a super good fisherman, a avid stamp collector, a musician, and actually the musician thing ties back to her college days because she performed in several orchestras on the cello and the violin even after she retired.
Oh, that's awesome.
And apparently,
keep your hobbies.
This is also like lore. I don't know if this is like true, but a patient once taught her how to build musical instruments. And so then she proceeded to make a cello, violin, mezzo cello, and a viola.
Oh my God. She was nonstop.
So she was out here.
Oh
no,
God,
it
like
continues.
What?
It continues. She learned how to fly a single engine plane in her 50s.
Oh my God.
Her spirit is just so like fun and free, and she like was so smart, but she also had all these hobbies and like all of this stuff that made her life really enriching.
That's so cool.
And so like I guess my last question for you, Charlotte, is like, what is something that you would like want to take away from Ginny's story, or like a pearl perhaps that you would want to take away?
I think it's awesome she kept with her hobbies, honestly. Like, I think all things she did was amazing. And obviously she just like followed her passions and like what she liked in her career and had a very successful career and was very busy, obviously. But then it sounds like she had a really successful personal life too, and like really found her hobbies and like followed them. I think that's really cool because I think people lose that really easily when you're busy and when you're focusing on your career, and especially people in medicine, like if you're working 80 hours a week in residency, like we're about to be like, I'm nervous for my hobbies. And it's something I'm like, I really want to keep going the best way I can, but I know it's going to be difficult and it's just like going to be a personal goal of mine. But it's really impressive to like keep things going in your personal life when you're really busy, like life in your career, I guess, as well. So that's kind of inspirational in a way. And I think it's something to look up to and try to strive to do, you know?
I agree. I think that was the thing about her that I also loved, and I just loved her like perseverance and I don't think like focused as much on her struggles, but she certainly had a lot of them. And I think she leaned on the right people and had enough support to make it through, and so I admired her for those reasons. But unfortunately, she died as we all do,
as people do,
from cirrhosis of the liver. For I don't know what happened. Like she wasn't like a heavy drinker or anything, but I guess it can happen. And
fatty
on
liver.
August 7th of 1974,
Non-fatty liver.
she
So many
passed
options.
away,
Damn.
unfortunately. But I wanted to leave us with a quote of hers that I thought was lovely and very apt for her work in like pediatrics. But she said, "Women are liberated from the time they leave the womb." And this is really evidenced in her life and the way she lived her life, because she never allowed her gender to impede her medical career. And I think that that's so special and so difficult for women of that time. And so I wanted to end with those words because I think that really does fit in the spirit of our work and our podcast.
I agree. I agree.
Yeah. But if you like listening to biographies and the lives and times of lovely women like Virginia Apgar, you should subscribe to the podcast and leave us a rating and review. Apple Podcasts is the best place for that, but you can also do it on Spotify and check us out on YouTube.
Yeah, you can also follow our social media. We have Instagram, Facebook, TikTok, Twitter, YouTube, all the things. You can also check out our website for more information. We have show notes, sources, links to our merch, which is at FromSkirtsToScrubs.com. And lastly, here is to the women who have fought for us to be where we are today, and may we do the same for those who come after us. And we'll see everybody next time.
See you next time, everyone.
Bye.
Bye.